All right, good afternoon, everyone. We're going to get started, sorry, with our final grand rounds of the academic year. The first speaker is Dr. Jennifer Manning. She received her medical degree from Nova. She completed her internal medicine residency at the University of Miami and subsequently pursued cardiology fellowship and advanced training in transplant cardiology at Northwestern. She serves as the director of the cardiac amyloid program, and her research interests are on advanced heart failure therapies and infiltrative cardiomyopathies with a focus on cardiac amyloid. She has authored numerous peer-reviewed publications and has served as a fit editor for the Journal of Cardiac Failure. A defining aspect of Dr. Manning's practice is her commitment to the early recognition and treatment of cardiac amyloid, integrative innovative therapies with compassionate patient-centered care. Please welcome Dr. Manning.
Hi, everyone. I am more than delighted to be here today. It's an honor to have the opportunity to speak to you guys about cardiac amyloidosis. It's not only such an important topic, but it is something very personal to me. I'm a little bit under a year back home, and it's been a pleasure and a privilege to be part of the program here. That being said, there is a lot nowadays to cover about cardiac amyloidosis, and we barely have 20 minutes. So let's get to it. I have no disclosures. So ATTR cardiomyopathy, this is a representation of transthyretin, TTR for short. This is a transport protein that is produced primarily by the liver. It serves to transport thyroid hormone as well as retinoid binding protein for complex. This protein exists as a homotetramer. However, as a result of aging or a variant, the protein can dissociate into monomers. These become insoluble, and they may aggregate into amyloid fibrils. Amyloid deposition into tissues, as you can expect, causes tissue damage. It particularly affects the heart and the peripheral nervous system. In terms of the heart, it would lead to a restrictive cardiomyopathy. And in terms of the nervous system, it will result in polyneuropathy as well as autonomic dysfunction. So how do we go about cardiac amyloidosis? And the first thing is to recognize the clinical characteristics, right? If you think about syphilis as the great masquerader, you can think about amyloid as even a greater masquerader in cardiac care. So think about potentially buckets. That's the way I like to think about cardiac amyloidosis. From a cardiac perspective, if you have someone with unexplained heart failure, think about amyloidosis. Someone with recurrent and difficult to treat arrhythmias, as well as those patients with low persisting elevated troponins. Low persisting elevated troponins is very common nowadays, but it doesn't mean that it's normal. That's a red flag, okay? Now, in terms of other patterns, when you see discordant QRS voltage compared to the degree of left ventricular hypertrophy, that should also be raising the red flags for cardiac amyloidosis. Now, just as important, extracardiac manifestations of amyloidosis are exceedingly common, and this is an opportunity for you to identify patients. I want to point out bilateral carpal tunnel syndrome, spinal stenosis, as well as tendon ruptures. These are common things that we're going to see in our PCP practices, in our everyday practices, not necessarily to the level of a cardiology visit. So let's look for those patients. Now, there are other cardiovascular phenotypes that should raise the possibility or the suspicion for cardiac amyloidosis. This is a prospective cohort that comes from Hopkins that look at patients with HFpEF, and these patients underwent endomyocardial biopsy. Up to 14% of patients with undefined HFpEF or just HFpEF had a diagnosis of amyloidosis based on a biopsy. So it goes to show you that ATTR is not only under-recognized, but it's also a treatable disease, a treatable etiology for HFpEF, so think about it. ATTR can also be present in patients with other conditions that can lead to LVH. There is extensive data about this. Up to 16% of patients who have aortic stenosis have a diagnosis of ATTR, and this is particularly important for low-flow, low-gradient AS. These patients will still benefit from TAVR interventions, but if you don't treat the ATTR cardiomyopathy, their outcomes are still going to be poor. On this side of the screen, to your right, you'll see data from the TRACK study. This was a multinational screening study that looked at patients with HCM above the age of 50. And what the investigators found is that 1 in 5 patients with a prior diagnosis of HCM had, in fact, ATTR cardiomyopathy, many of which were wild type. So again, if you have a patient that is coming into your clinic and carries a diagnosis of HCM, Don't accept the diagnosis, question the diagnosis, please. Irrespective of whether or not the patient is on treatment, you'll be surprised how often we see that scenario. Imaging red flags, this is usually the first imaging modality that will raise the question of cardiac amyloidosis. It's an echo. Common findings are LPH, as I talked about, particularly a posterior wall thickness of 1.2 centimeters or more. You'll see biatrial enlargement. You'll see basically the restrictive phenotype. You'll see a grade 3 diastolic dysfunction, low Doppler velocities, and the classic Sherry on top or apical sparing strain. So this refers to preservation of the apical wall in terms of strain compared to the basal or the mid left ventricular segments. So if you ever see this in a report, please think of cardiac amyloidosis. Is it specific? No. Is it sensitive? Yes. Does it deserve your attention? 100%. I volunteer. If you have questions, you can message me and I will help you, but please do not ignore this finding. Now, cardiac MRI. So cardiac MRI offers tissue characterization like no other imaging modality. I am not a cardiac MRI expert. I am a cardiac MRI enthusiast. So if you come to my clinic, I will find a reason to get a cardiac MRI because it has the potential to alter how we treat you, okay? Hallmark, classic hallmark, it's diffuse late gadolinium enhancement. It's diffuse subendocardial LGE that can progress to transmural in patients who have a later disease stage. That being said, more contemporary markers of cardiac amyloid burden, it's ACV, extracellular volume mapping. So this is basically a direct measurement of the extracellular expansion caused by the amyloid fibrous deposition. This is data from Fontana. She is the director of the Cardiac Amyloidosis Center at the UK Center. She has done tremendous amount of work in the field. We're very grateful for that. And you can see here in this marker that we start with very subtle cardiac remodeling that can lead to an overt restrictive phenotype. But what I want to point out here in this image in particular is the fact that if you look at the behavior of ECV, you will have changes in ECV that precede the classic overt LGE and left ventricular hypertrophy. Again, there is a lot of data. There is emerging data of the use of this as a prognostic factor as well as a way to see the progression of your patients. Now we're going to go back to real life, regular clinic day, and we have a patient who's 73-year-old Black Hispanic male that is presenting to our regular cardiology clinic, per se, not necessarily our cardiac amyloidosis clinic, for evaluation of progressive dyspnea. I saw this patient in October 2025. Previously, he had been suffering from shortness of breath for about 3 years. He had seen pulmonology, no significant findings there. He had previously seen a cardiology. His workup included a stress test and an echo that was deemed normal. He was referred for weight management clinic. Perhaps the patient is just a little overweight. Ultimately, there was progression of symptoms. He comes up to our clinic. You go to cardiology clinic, you get an ECG. That is my first encounter with the patient is the ECG before I even open the door. There is some atrial arrhythmias, right? So that could technically explain the reason why this patient is short of breath. A little bit of low voltage. Okay, we'll see. Now, again, I go back to the records. There is a prior echo about 3 years ago that says normal with an LVEF of about 60%, so mild LVH. The images are not available, but the report is there. Now, this is me. I think about cardiac amyloidosis every single day, including when I go to Publix. If I see you with lower extremity edema, I'm looking to see how you're walking. So talking to this patient, he has a history of hypertension, hypertension for 10 years. Control, this is a Hispanic patient. Control can mean different things for different patients. So it doesn't correlate with what I would expect, LBH, but now all of a sudden I'm seeing low voltage. And then you talk to the patient and they're really not overt volume retention, but there's some ankle edema. Now, I start asking questions that make me look a little crazy. If you go to cardiology clinic and I'm asking about bilateral carpal tunnel syndrome, I oftentimes get the faces of, why are we talking about that? But nonetheless, this patient did have 3 other red flags. And this is a real case. This is a patient with bilateral carpal tunnel syndrome, status post, release surgery many years ago, sort of classic, and we'll talk about that. Lumbar spinal stenosis, as well as spontaneous bicep tendon rupture. From all the patients of cardiac amyloidosis I've seen like about 4 patients with tendon rupture. But you need to ask, okay? I don't need to ask anything else. I am highly suspicious that these patients have cardiac amyloidosis, but we can go based on what I think. We need to prove it. How do we do that? Before we do that, I want to highlight something in particular. I already alluded to red flags. I talked about carpal tunnel syndrome, but I think this is important enough that it deserves its own slide. There is plenty of data that associates carpal tunnel syndrome as well as lumbar spinal stenosis with patients with ATTR cardiomyopathy. The data suggests that these patients will have these orthopedic manifestations 5 to 10 years before there is cardiac involvement. In this multi-center international study cohort of about 1,500 patients, you can see that up to 29% of the patients had bilateral carpal tunnel syndrome, 22% of the patients had spinal stenosis. We know that. But what we didn't know, or what we are actually learning now, is that these patients tend to have better outcomes. Their survival is better. And you wonder why. Because we are actually encountering these patients early. Oftentimes they'll get a biopsy, comes back with amyloid deposits, they end up in my clinic. So this is a very important patient population that represents a patient that we can target it in terms of screening. So I like to think of carpal tunnel syndrome as stage A heart failure. That's the way I see it. So I got an echo from my patient, and this is the emoji to represent how I felt. This is classic. Everything that we have talked about, massive LBH, it's biatrial enlargement, it's restrictive. This is pretty sad, if you ask me. Does this diagnose ATTR? It does not. So this is the workflow. This is published recently in Circulation. This is the latest clinical guidance for clinicians. I highly encourage you to read it. It's very short, to the point. But ultimately, once you have the clinical suspicion, once you have the imaging finding, the number one step for ATTR cardiomyopathy is to rule out a monoclonal process. You have to rule out you have to send what I call AL screening labs. That means serum and urine immunofixation, as well as the serum-free kappa-lambda ratio. Please, please, please do not send UPEP, SPEP. It does not rule out AL. And the reason being is because the amyloid fibers are small enough that sometimes can give you a false negative. So send for immunofixation, direct immunofixation. If unfortunately it comes back positive and we're dealing with AL, we will talk about SPEP and UPEP. And then you order with bone scintigraphy, and we'll talk a little bit more about what that means. And ultimately, if your AL screening labs are negative, you go through the non-invasive pathway, bone scintigraphy, and then afterwards, once it's confirmed, we'll look for genetic testing, okay? So bone scintigraphy, what does this mean? This is the common PYP scan. PYP just refers to the radiotracer used. There are 2 other ones, one approved in the US, one in Europe. But basically, it is as simple as it gets. Ignore my ignorance. I am not a reader, but it's very simple to understand, right? You give a tracer, you look, and you quantify the myocardial uptake. That being said, simple comes with simple mistakes that can have deleterious effects in the patient care. And what do I mean by that? In order for this test to be a real, very good test and a validated test, you need to look for SPECT CT or even SPECT to not only quantify this as a qualitative, but also ensure that you're looking at myocardial uptake, not myocardial pool, not blood pool. There is this paper here that I wanted to highlight. Is a small, very, very easy to read, short paper on PYP pitfalls published in JACC. And I want to point out that Dr. Hoffman from hematology here is one of the authors, among many other cardiologists. So shout out to him. Now, tell me about the impact of non-invasive diagnosis of cardiac amyloidosis. You think about it many years ago, on top of the fact that we didn't have any treatment options, it was difficult to diagnose these patients. These patients will require biopsy. That is no longer the case. As long as you have negative AL screening labs, you could go through the non-invasive diagnostic pathway. And that has had tremendous positive implications for the field. What do I mean by that? This is data looking at patients who were diagnosed pre and post the implementation of this pathway. And you can see that after 2016, patients are diagnosed with a less severe phenotype. There's less heart failure, there's less symptoms, and their outcomes are better. So again, this has been a win for the field. Now, for our case, as I said, the echo was representative, but we cannot go by the echo. So this is the PYP scan of our patient. There is no question about myocardial uptake here. You could see it. Classic. We knew this. He had all the clinical red flags. Not all of your patients are going to be that classic patient, but you will find them if you look for it. So in terms of treatment landscape, I love this slide. I'm not going to go over it. It has tons of details, but this is the amount of work that the field has done to change how we manage these patients, to change the outcomes of these patients. And now we have multiple diseases that target the disease process at different stages. We have from a stabilizer that prevents the tetramer dissociation from onto a silencer, and we're looking about gen editing and as well as depleters. So in terms of disease-modifying therapies for our patients, these are 3 landmark clinical trials. We started with tafamidis, the ATTRACT trial, that showed that stabilizers do improve survival and decrease cardiovascular hospitalization for patients. This is the first FDA-approved drug for ATTR. This trial was the first trial to shine light in the fact that in order for these therapies to work, we need to initiate the therapies sooner rather than later. That means the clinical benefit is there when you have New York Heart Association Class 2. The moment you start into 3 and 4, the benefit is less. There is already extensive cardiac remodeling. And as a reminder, this is a stabilizer. This prevents further progression, but it does not result in regression of the disease. Then you have acoramidis. It decreases the hierarchical endpoint of mortality, cardiovascular hospitalization, NT-proBNP, and a 6-minute walk test. And ultimately, butusiran, which is a silencer, and it was a clean-cut data that it decreased the death risk in cardiovascular events. So we have easy screening, does not require biopsy. We have plenty of drugs to treat this disease. Now, if you ask me, we're changing a little bit of how we look cardiac amyloidosis. I think now we have to concentrate on timing of diagnosis. Timing of diagnosis is just as important as the choice of therapy. Why? If you look at the 3 trials together, you can see that across the spectrum of all 3 trials, the earlier the patients are diagnosed, the better the outcomes. So again, proactive screening, early diagnosis, and early initiation of therapy should be the way we think about cardiac amyloidosis nowadays. This is again from that clinical document that I share. This is the landscape of real-life treatment for these patients. So do we have data on combination therapy? We do not. Do we have data to say that one agent is better than the other one? We do not. So how do we approach this? This is precision medicine 101. Every patient is an individual person that will merit a specific evaluation and a discussion, and you have to select what the best treatment option is for your patient. At the same time, let's not forget that this is just to prevent further progression of the cardiomyopathy, but you still have to treat the heart failure. How do we do that? It depends. That's the answer. Every patient is going to be different. This is not every patient is going to be in all 4 agents of GDMT. They often actually do not tolerate it. I have patients, all 4 agents, doing great at the gym. I have patients that I've started 12.5 metoprolol, and they're calling me about to syncopize. So it really just depends. What I do want to highlight here, this is across the board. The thrombotic risk is really, really high. So if the patient has AFib, please anticoagulate your patient. Please anticoagulate, and please anticoagulate. I'm trying to drive the point that the thrombosis risk of these patients is pretty high. This is not standard of care. This is something that I do to my clinic. If you go to the cardiac amyloidosis clinic, I will get a Zio patch to try to catch any underlying AFib or flutter that is asymptomatic, because it's that detrimental for patients when they end up with a stroke. Now let's go back to our case. We now have a diagnosis. So what are we going to do? We're going to navigate treatment decision. Our patients are becoming very well versed in the literature in terms of amyloidosis. So they'll come with questions, specific questions about different agents. And for this particular patient, we decided, with the help of the patient and his family, on a stabilizer. Let's not forget, I said once you diagnose, you have to send for genetic testing. Please do not take into account whether your patient is 75 or 92 years old, because it has an effect on their significant others. So this patient went for genetic testing, and it turned out that he was B122I positive, and we're going to talk about what this means. Are we done? We are not. This is his cardiac MRI. And many of you would say, why would you get a cardiac MRI if you already have a PYP scan that is positive? You don't need a cardiac MRI to diagnose. The gold standard is PYP. As I said, I was very enthusiastic in terms of cardiac amyloidosis and MRIs or anything heart failure related per se. But you can see here, let's talk about genetics first, and then we'll go back to the point of the cardiac MRI. In terms of genetic variants, B30M mutation is the most common mutation worldwide, up to 76% of the cases. Now, in the United States here, the most common mutation is B122I, up to 23% of the cases. This mutation is carried in 3.5% of those patients who consider themselves Blacks. So that translates into a lot of our patients that we see every day at the University of Miami and Jackson that being potential carriers of this disease. Now, this is, again, data from the UK Amyloidosis Center that looked at, is B122I just a regular variant? Is it just ATTR cardiomyopathy in a different patient population? But no, it turns out that it's biological different. Compared to wild type, this is propensity match, the disease is more aggressive, the level of remodeling is more aggressive, and the progression or outcomes are more for patients with B122I mutations. So again, cardiac MRI, I use it as a level to prognosticate these patients. At what degree of fibrosis are we diagnosing? What are we expecting? So for this patient, he's positive B122I mutation. I'm recommending screening for first-degree relatives, and there is a couple of things that can come back to you. Family members are negative, you're done. Family members are positive and they have the disease clinically, you start treatment. You start talking about different ways to manage their condition. Or you have patients who are what we call genotype positive, phenotype negative. Their mutation is there, but they have no symptoms. And trust me, guys, I will try to find the symptoms. I will try to find that cardiac remodeling. And there are patients that don't have it. So what do you do with these patients? This is data, again, particularly looking at B122I mutation that says that cardiac remodeling often precedes clinical heart failure by years. So you'll see that low level of cardiac disease. And the risk of heart failure and worse clinical outcomes is still there. So I include a cardiac MRI in part of the diagnostic workup of these patients, not just a PYP scan, again, to see what the ECV is looking like, to see if there is any negative remodeling. As of right now, there is no specific data or robust data to say that there is a benefit to start disease-modifying therapies for patients who are genotype positive, phenotype negative. Now, if you ask me, in a couple of years, we're going to be talking about a different ballgame altogether. So, in short case overview, this patient started with shortness of breath in 2022, already had carpal tunnel syndrome, already has spinal stenosis, and bicentennial rupture, and he was missed. He was sent to pulmonology, extensive workup, everything was negative. He was sent to cardiology, including an echo that was read as normal because it was just mild LVH, whatever that means. In September, he was sent to the weight clinic, lost some weight, and he still progressed. And it was not until 3 years later that he comes to our clinic and gets diagnosed. He was started in treatment right away, but unfortunately by December, he already had his first heart failure admission. So in my opinion, this is a missed opportunity to treat a treatable and not reversible, I should say, but a treatable disease where you had the chance to prevent further progression. With that in mind, and I apologize because I've been talking very fast, I want to say that as the awareness of cardiac amyloidosis continues to grow, our effort here at the University of Miami have been to build a comprehensive cardiac amyloidosis program that is centered on early recognition, yesterday diagnosis, that's the way I like to think of it, and rapid initiation of therapy. This has been an effort across the board. I appreciate everyone's support, especially hematology. Dr. Hoffman has been instrumental to the build of the program. His expertise in AL are tremendous, and our patients benefit from it. We are, I would say, committed is just, it's not the right word. We live for our patients. We want our patients to have the best care, and that includes clinical trials. We are very lucky to have Dr. Weaver Pinson, who brought the TRITON cardiomyopathy trial. We are currently enrolling patients. There is ACT early. And we just submitted a grant for Pfizer for a tool to help our patients navigate this complex diagnosis. Thank you very much.
Dr. Manning, that was wonderful. Thank you so much. Learned so much from that, and I appreciate it very much. However, I would take a different tact a little bit, perhaps, and comment on this. I think it's much cheaper today to do whole genome sequencing and get a genotype than it is to even wait and order a cardiac MRI and the expense that's involved. And wouldn't it be so much easier to start to reverse that paradigm that you had to put the genetic testing up front? And if so, how early would you start initiating, especially in Afro-Caribbean populations where we know there is a pathogenic mutation that can be easily detected? How early would you detect? So, would you really do that? I certainly, today you can get whole exome sequencing, in 2 weeks back in analysis. What's your comments?
Thank you so much. Excellent question. I actually didn't bring it up, but if you come to clinic, you'll get genetic testing, even if you're coming for toe pain. So I couldn't agree more. I really mean it, guys. My nursing staff, they know. So to answer your question about when should you start screening, I think the earlier the better. And I say that based on patients who are not the classic phenotype that wait until their 50s to have disease, especially the B122I. So I would say that earlier than that, like even mid-40s. Now, I have had a patient who diagnosed herself with carrying the mutation with 23andMe. She got it as a present for Christmas. So I could not agree more. No, wait, let's just start early on. I would say the minimum, I would say it's like 40s, early 40s, because that would be 10 years lag. And that being said, if you have the ability to do that before, 100%, why wait?
It would seem to me that those ongoing studies now, if you get involved in starting some remittive agent or some stabilizing agent, that you could then look over a period of time how you've affected the natural history of their heart failure. I know those studies aren't available yet. Well, thank you so much. That was great. We'll move on to our next speaker.
All right, for our second speaker, we have Dr. Jani. He's a chief fellow in hematology and oncology at Sylvester Cancer Center. He completed his internal medicine residency and served as chief resident at Mount Auburn Hospital and before pursuing fellowship here at the University of Miami. His clinical research interests focus on thoracic oncology, precision medicine, early phase clinical trials, immunotherapy, liquid biopsy technologies, and biomarker-driven drug development. Dr. Jani is actively involved in clinical trial development and translational research with particular interest in integrating multi-omics approaches, artificial intelligence, and innovative therapeutics to advance personalized cancer care. He will be joining the University of Miami faculty as assistant professor in thoracic oncology and experimental therapeutics, where he plans to continue his work in early drug development and precision oncology. Please welcome Dr. Jani.
Thank you so much for having me. Good afternoon, everyone. I'm going to talk about oncology updates from 2024 and 2025. So our learning objectives will be looking into cancer screening quickly, molecular testing, and the new treatment classes, focusing also on the adverse reactions, and then understanding why phase 1 trials are increasingly used earlier in precision oncology. So Dr. Lopes is my mentor for past 3 years, and he told me to go and get a bucket from Pacific Ocean, and that's what I'm going to do, giving you updates of oncology for 2025-2026, the most difficult task possible as a fellow right now, because the field is constantly moving. Last year, we had 14 drug approvals out of 50 or something just in oncology through FDA. So here we are talking quickly what is most pertinent for internal medicine. So we're going to go through modern oncology continuum because it touches on various different aspects about it. And then I really want to focus on IRAE, CRS, and ILD because these patients, you'll be seeing them in clinic. You're also going to see them in the hospital as well so that you know how to identify when this kind of side effects are arising. Before we dive deep into it, lung cancer screening, giving a big shout out over here for lung cancer screening. And the reason is there's a big unmet need. Even though we have shown by multiple different trials, NLST, Nelson trial, that lung cancer screening reduces mortality, catches the lung cancer incidence at an earlier stage, it's only done in less than 20% of patient population. So each clinic is a screening opportunity. So if you have a patient who is having smoking history within the age of 50 to 80 years, please discuss with them, send it to lung cancer screening program. This is a great slide for internal medicine as well. Lung cancer screening, 50 to 80. We have colorectal screening, 45 to 75. It's constantly evolving, but it's at least helpful to have the basic ones. Breast cancer screening, biennial mammography for women 40 to 74 years. Cervical screening and prostate cancer screening is more kind of shared decision making right now. And avoid routine screening age 70 plus. But again, shared decision making is always going to be helpful. So there was recent update in ASCO from multi-cancer early detection as well. I'm sure you would be hearing about this from your patients asking. Our patients are asking us in oncology clinic as well. Is there any such test which can give us information about cancer, any type of cancer from earlier end? So there was a lot of studies happening. There were a lot of studies happening few decades back, and now the field is coming back into place. So this trial was shown at ASCO 2026, which was literally last weekend, NHS Gallery trial, and it showed that there was certainly some increase in stage 4 detection. But when we looked into stage 3 and stage 4 both, it did not show good enough outcomes, and mortality data is still like premature to come. So as of now, the jury is not on this, that it should be utilized, but there is more and more data coming out on how this can change the cancer screening. Then comes to molecular biology. So when I was in medical school, all we used to know was pathology, IHC testing, that TTF1 was the one for lung cancer. Now it is constantly changing. And why is it changing? It's because of molecular testing. Each particular molecular alteration in lung cancer, pancreas cancer, breast cancer is extremely different from the other one. And it's almost acting as a separate entity. So what are we going to go and discuss about it? So we're going to talk about molecular profiling, NGS and ctDNA. We're also going to look into biomarker match treatments as well. So this was non-small cell lung cancer. Again, 15 to 16 years back, beginning of med school time as well. And this is what it is right now. And it's still constantly evolving. And there's no alterations is even evolving further and further as well. So maybe in a year or two, this will have further more branching out as well. And therefore, tissue is extremely helpful in histology and architecture. It gives us information of PD-L1 expression. It also gives us information about HER2 expression, which you would have heard from breast cancer as well. But now HER2 is utilized in colorectal cancer. It is utilized in non-small cell lung cancer and many other solid tumors as well. It is still the gold standard of diagnosis, but as we know, it's invasive, limited quantity. At the same time, liquid biopsy is a complementary testing. It's not completely replacing it, but it gives us more information about actionable mutations as well, and can be utilized for resistance testing as well as at progression. How is it happening? And along with that, looking into minimal residual disease, which is on neoadjuvant side, adjuvant sites if the patients have received treatment as a stage 3 setting. And if you want to discuss with them when should a treatment be escalated, then liquid biopsy can be certainly extremely helpful to you all. This was our study, which we showed at KCR 2024, but it was recently published out, which showed this exact analysis, how it is concordant. And the main results which I want to showcase over here is just highlighting on this purple colored portion of the graphs. You can see TP53, TERT, BRCA2, ATM, all these mutations were only identified in ctDNA, which was liquid biopsy. Which means if we would have just done tissue biopsy, it would have identified other alterations, but it would have not identified these alterations. Therefore, when a patient is coming to our clinic now, we do both tissue and liquid biopsy both. Why giving this plug over here? Many times when the patients are directly admitted in the hospital, sometimes in ICU as well, we are waiting for molecular testing to come back. The reason is because if we give some treatment which is not going to work from them, it is going to actually harm them more rather than helping. And that's the reason you would be listening from the oncology team. Let's hold off till the molecular testing is coming back. We do sometimes give 1 or 2 cycles of chemotherapy to stabilize, but most of the results have shown, even in those settings, it's better to hold off as and when possible. And that's one of the rationale for this. The next one is, again, precision medicine for various different cancers. And in this ASCO 2026, there were so many different studies showcasing various different information in molecular testing, especially on KRAS. And we'll dive a little bit deep into KRAS as well. But broad panel testing versus shorter panel testing. Here at University of Miami, our basic focus is to do broad panel testing. We have multiple vendors. We can also do at Jackson Memorial Hospital as well with Garden testing, Lucent's testing, LabCorp, Quest, etc. And based on this testing, we decide what next treatment to be done. And oncogene-driven disease is actually helpful to see what exact testing is coming back, because even immunotherapy-induced toxicities can arise, and it's not completely safe enough. It has really great benefits. But if you can avoid in those patients with molecular testing, it's better to do it. And we had an M&M case in the similar scenario as well, where the patient eventually turned out to be EGFR mutation positive. So just giving this highlight once again. So this is what precision medicine currently looks like. I really like this picture. It's from prostate cancer. It starts from early detection, risk stratification, then goes into treatment guidance. Then it looks into response assessment as well, and then treatment resistance and characterization too. So that's where all the omics, DNA, RNA, everything comes into play. So everywhere is now precision medicine involved. And at every different time point of a patient's journey of a particular disease, we do liquid biopsy or tissue biopsy with molecular testing as and when possible. And in that, one more thing is ctDNA along with ctRNA. It's even more impactful. And why? Because you can see over here that there are intronic breakpoints which are not completely conducted through ctDNA. Therefore, when you do ctDNA and ctRNA both, as you can see over here, it can detect more fusions as compared to not detecting, as compared to the one which are not fusion associated. Which are fusion associated? You would have easily heard ALK fusion, right, in the lung cancer. ALK is the most common fusion detected in various different molecular testing. So if we do ctRNA plus ctDNA, then it will have even better detection rate. And we do have even at Jackson as well as Sylvester both platforms which can do both ctDNA plus ctRNA. One of the name for that platform is called Lucent's platform. And this is under embargoed right now, but we are going to, Dr. Lopes and we are going to present this at an oral presentation at World Lung, showcasing the exact results that ALK, ROS1, RET, as well as FGFR, NTRK, and NRG1 rearrangements were detected when ctRNA analysis was done. Therefore, as and when possible, it's better to do ctDNA plus ctRNA. Then going quickly into another study, just showcasing why it is important even to test liquid biopsy when the patient is having progression of disease. So we looked into Guardant Inform database, looking into prostate cancer in pre and post treatment with taxanes, PARP inhibitors, and ARPIs. PARP inhibitors is the targeted therapy that is given for BRCA. Taxanes are the typical old chemotherapies, and ARPIs are the targeted therapies particularly used for prostate cancer. And these are the results that you can see. Again, highlighting over here in the orange with our University of Miami color, that these are the newly detected after PARP inhibitor, newly detected after taxanes, which if we would have not done liquid biopsy and we would have just transitioned to usual NCCN or ASCO guidelines-based therapy, we would have missed these treatments. And there is one more thing which I want to give a plug. It's CHIP mutations, which is a lot more data and literature coming out from hematology, which means it's a clonal hematopoiesis of unknown significance. But now even in solid oncology, these mutations and these platforms can help us identify which is actually helpful and which is not helpful. Therefore, this can give you more information about newer mutations arising. So whenever there is a question of progression, we do again liquid biopsy. Just giving this information out again and again, because these patients, when they leave our clinic, they immediately come across to ACC West, and then they talk to you, and then they tell you that, oh, we had another biopsy, and they're completely confused. So you will be able to inform what that biopsy was potentially. And here another portion as well. So when you do liquid biopsy serial testing, it also gives information on how tumor biology is evolving. So far, we were never able to understand why is a patient developing resistance, or what is underlying prostate cancer biology, or what is underlying lung cancer biology. Now with liquid biopsy testing, along with tissue biopsy as well, it can give you more information, not just on resistance mechanism, but also tells you what are underlying reasons happening that the cancer is progressing and getting more and more worse, and sometimes transitioning into small cell or neuroendocrine status. So what we showed over here, you can see AR mutations, and the ones which are AR mutations positive, which are AR mutations negative. AR is androgen receptor mutations, which is the underlying physiology, pathology for prostate cancer. And this study has never been, these results were never shown before in a real world evidence way, that those patients who had AR mutations and had progression after PARP inhibitors or taxanes, even in those patients with having AR mutations, survival was low. This means that AR mutations is actually underlying pathology, and it's the underlying reason for tumor biology evolution. And therefore, it should not be just important for ARPIs, which are the targeted therapy for this resistant mutation, but it should be helpful for any prostate cancer patients. And that's what we showcased over in this study. It was recently published in Clinical Cancer Research, and just showcasing that, again, precision medicine is extremely important. Giving a plug from ASCO 2026, this was a study presented on this Sunday, just 2 days back, showcasing the importance of MRD testing and ctDNA dynamics in immune checkpoint inhibitor. This is from colorectal cancer, so jumping from GU to colorectal. And just putting these 3 things, if you can focus over here, which means that 81% of ctDNA clearance occurred on patients who had immunotherapy, and those who were ctDNA negative, which means they had no MRD detection of any tumor cells coming out in the blood, they had 93.1% of survival versus 76.1% of 3-year survival. And again, similarly, who achieved clearance was again 95.7% versus 68.6% remaining persistently positive. As of now, we don't take actions. Let's say if the patient becomes ctDNA positive, we do not change the treatment or add on different treatment, but it will just give us more information that this patient could be progressing earlier enough than in other settings. And therefore, including this MRD testing is going to be more and more helpful in treatment decision-making. Next is again utilizing on, again, smoking history as well as synthetic biomarkers. So very often, I have been in internal medicine clinic, and you know that patients do not give correct information of smoking. And smoking changes a lot of different risk factors, not only in just oncology, but in cardiology as well, in multiple different fields too. So now with ctDNA and genomic testing, you can identify if the patient was actually smoking or not, or had any exposure to smoking, or even passive smoking history. And then in the western part of the country, southwest, if they had fire smoking history, so it can give you information of that as well. And there is more synthetic biomarkers coming out as well. But this is another study which we focused on AYA population, as you are seeing that cancer is getting detected in the earlier stage setting as well, which means at the age of 30, 40, etc. And we looked into how is this molecular testing evolving, because they don't have as much of smoking history. They don't have any other risk factors as well. And as you can see over here, tier 1 is those actionable alterations where we can do targeted therapy. And the younger the age, higher are those alterations, which means it's a different pathology and diagnosis in this early stage population. And this is again our study going to be showcased at World Lung. And here I want to show KRAS. And KRAS till date has always been non-druggable, non-targetable. It was always that, yes, we know KRAS is there, but what to do? And especially even when I was doing this study, I was revising myself in lung cancer that KRAS is the most common mutation in lung cancer as well, in particular age population, but still is the most common. So why am I saying so much about KRAS? And the reason is this. There was a big standing ovation, which I'll showcase as well, at ASCO 2026, showcasing that KRAS can now be targeted upon. There was the first discovered in 1982, moving on to 2021. We had a divarasib plus pembrolizumab showing some activity as well. And in KRAS as well, there is KRAS G12C, G12D. There are various different subtypes too. Too much of details as of now, but more important is this, what I want to highlight in center. Daraxonrasib. It's a mouthful for the name, but it was the Razolute or 302, which was a trial showcased. And it showed that in the pancreas, in the patients with pancreatic adenocarcinoma, overall survival doubled. All those of you have heard of, you have taken care of patients with pancreas cancer, survival is extremely poor. Progression-free survival is extremely poor as well, and overall survival too. And you can see it's a double jump. People in Chicago were extremely emotional, truly, and you can see what happened. It was like a big standing ovation on Saturday, Sunday, I forgot, and it went on for long and long and long, because after such a long time, after many decades, GI cancer are now showing some progress as well. So if you have now a GI cancer patient in ICU, don't think that the patient will completely be hospice candidate. This patient could potentially have some treatment, especially if it's KRAS positive. That's why showcasing these results over here. And as a final slide for precision medicine, just as a repetition, we saw how it is important cancer detection, then it is important molecular profiling and prognostication, detection of residual disease as well, as we saw in one of the studies showed at ASCO, monitoring response. If it is going down, then you think whatever is happening is good. If it starts going up, you just have low threshold to do more testing and do more analysis. And then clonal evolution. I also showcase how AR alteration could be underlying reason for tumor biology as well. Going into novel therapeutics quickly, which is bispecific antibody. This was something when I was resident I didn't know as well because it was still under drug development and novel therapeutics. But now it's already in the market, in the FDA approval, and we're giving this patients. What is bispecific? It's in a typical English term. Thankfully, it's not Greek or Latin. It's literally bispecific. Two cells are targeted with this bispecific drug. In bispecific, there is one more subcategory, which is BiTE, which is a T cell engager. So let's say if these two receptors were tumor cell and another tumor cell as well, then it's just a bispecific. But if this one is a T cell, then it becomes BiTE, which is a subgroup. Now, in BiTE, tarlatamab is the most common drug right now being used in solid oncology. There are way more on hematology side as well. But again, focusing on solid tumor. And this is now currently used in small cell lung cancer as well as in high-grade neuroendocrine carcinomas as well. For bispecific, there is amivantamab, which is EGFR and MET bispecific, again targeting on two different receptors, and it can be utilized in lung cancer. It's coming into head and neck cancer as well. And the most common with this is rash, paronychia, edema, and also clots, VTE. And with tarlatamab, I'll showcase what are the most common side effects. Just quickly talking about amivantamab over here, atypical EGFR treatment naive, those patients who are having EGFR atypical mutations or regular mutations as well. There has been a lot of different benefits of survival shown as well, and it significantly improves CNS symptoms as well. This is from ASCO 2026, but there has been a lot of data already existing, and we are utilizing in our clinics at Sylvester. And I think so 1 or 2 patients, we also utilized it in Jackson as well. So this patient population is very much possible. Why you should know? Because these bispecifics lead to a lot of different rash, really severe rash, mucocutaneous inflammation as well. And if you are seeing any of these side effects, it's probably because of amivantamab. Please reach out to us and we would help you co-manage this patient population as well. There was a different study, again at ivonescimab at ASCO 2026 as well. And this is a different bispecific, PD-1 with VEGF. VEGF story is that VEGF used to be a very common drug, which is bevacizumab. Ophthalmologists use a lot as well as in various other fields. Now it's coming back into oncology market again, sometimes in the form of bispecifics. And this was the first drug in plenary after 60 years, which was developed in China purely. We still don't have approval, but there are trials ongoing in United States. It has shown that it has benefit in lung cancer as well as in other cancers here in US as well. And it has shown great overall survival benefit that the patients survive almost double and great overall reduction in risk of death as well as progression-free survival as well. And this is one slide if you want to take from the immunotherapy portion is again this, which is all the IRAs, just giving a revision again. Pulmonary toxicity, neurologic toxicity, endocrine, which is thyroiditis, the most common. Skin reactions, hepatitis, cardiac, we just had the previous lecture, and we, Dr. Shajizis, and we are doing a project on triple M as well, myocarditis, myasthenia gravis, and myositis. And in University of Miami, we had 14 patients, probably around the whole country, there is less than like 80 patients, just showcasing that if a patient is receiving immunotherapy and if you see constellation of symptoms, don't think they're completely separate. Probably it might be just because of one drug. And usually treatment starts from steroids, but you can easily look up IRAEs, which is immune-related adverse events, and then treat based on that. The reason why I'm highlighting again this over here is you would have heard this in your didactics before, but there was a patient who recently came even to my clinic, had rash, and had already gone to dermatologist, got a biopsy, but the underlying reason was immunotherapy-associated rash, or it was a dermatitis. So that's why just showcasing why it's important. Going directly over here, key agents in thoracic oncology, tarlatamab, ivonescimab, amivantamab, as we quickly discussed. And in tarlatamab, the most common things that you need to now know is CRS and ICANS. Probably you will see this CRS and ICANS more in UHealth because these patients are currently getting admitted at UHealth. We do not have yet any patients at Jackson. But if any patients who are developing sepsis-like scenario, in those patients who have received tarlatamab, hypotension, fever, and vital signs abnormalities is usually because of CRS. And again, any confusion, nausea, dizziness, it could be because of ICANS, neurotoxicity, which is happening because of these new bites. A shout out to one of the residents, Santiago. We presented our data from University of Miami as well in patients on how is tarlatamab utilizing in brain metastasis and Hispanic heavy population as well. And no one has yet shown similar data at ASCO. So this was us again last weekend. And we saw that the patients who were even highly having CNS metastasis, tarlatamab worked really well. So small cell lung cancer is also making great strides right now. This is one picture. For all the residents, I would recommend is to take picture of this slide. This is for cytokine release syndrome, grade 1, 2, 3, 4. This is for one of our review article, which will be coming out very soon. And it just showcases that what treatment to be given and when to be given. It starts from Tylenol, goes on to tocilizumab. If you all remember COVID-19 time, or we still have some COVID-19 as well, it's similar mechanism of CRS, even for bites, because it activates immune system. And then as and when needed, vasopressors and steroids as well, if needed. But this slide will help you a lot. And if eventually I can send this to you all as well. The last one is ADCs. I forgot the name Trojan horse last time when I was talking. I kept on saying some Greek mythology, but now I remember what is Trojan horse. So it is literally like that. It attacks on the target antibody and it has this payload, which was the old chemotherapies. If you all remember Dr. Hurley, some of you, if you were here before, she always used to say these were all the chemotherapies on the shelf and now they're coming back and they can be delivered directly on the target in a very precise medicine way. And why? Because it reduces the side effects. These are the current 3 approved ADCs, Dato-DXd, T-DXd, and SG, various different ways, various different indications as well, mainly HER2 positive, which you would have heard in breast cancer, also coming now in GI cancers and lung cancers as well. And there's TROP2 again in lung cancer as well. Lots of different names. Why I wanted to highlight over here is ILD. These patients develop very typical symptom as if the patients are having pneumonia. So patient is any of these ADCs and they're getting admitted in ICU, they're getting admitted in hospital. Think about that this is drug-associated ILD. Please reach out to oncology. We won't say, why did you consult us? We'll help you out. And then the last portion I'll highlight is phase 1 trials. You have heard from us in oncology, hematology, the trials are very important. And again, when I was in med school as well, we used to think that phase 1 trials were the last resort, which is no more the case. We have various newer and newer treatments which are available in the earlier stage setting as well. And the newer treatments are having better activity and better outcomes than the standard of care. That's why phase 1 trials are even getting more and more important right now. There are novel ADCs, bispecifics, radioligand therapies as well, oncolytic viruses. And you all know this, GCRB right across, just a few steps away. We still don't have Cortadito there, but hopefully we'll have it very soon. It's an ongoing process, but this is our phase 1 staff over there. We have like multiple different investigators. This is constantly evolving. I'll be joining this team along with thoracic oncology as well. And we are really pioneering for oncolytic virus therapies, diagnostics, ADCs. I had an opportunity to present one of the IITs from Sylvester at ASCO as well, just showcasing our strength, especially in South Florida, but also across the nation too. And this is just a small portfolio, and it's constantly evolving in the phase 1 as well. And this is for Dr. Weiss, so he thinks that the grant was given in a nicer way. I just received a grant from Department of Medicine for AI, and we were able to showcase at ASCO on podium, showcasing the benefit and highlight of AI in lung cancer as well. So AI is not getting missed out in oncology anymore. We were able to utilize in shared decision-making and how the clinical landscape is evolving. And this is just, we looked into various different LLM tools, as well as ASCO AI and open evidence as well, and how is it concordant with thoracic experts, and it was quite concordant, 80%. And ASCO really liked it. We are going to do more and more work with ASCO team in future as well. So as a summary, screening remains foundational. Please talk with your patients. Molecular testing is now standard, so we wait for molecular testing whenever before starting treatment. Liquid biopsy is a real-world practice for evolution as well. Novel therapies bring novel toxicities. Please identify them. Please reach out to us. And think phase 1 earlier, not as a last resort. And these questions were already sent out, so we don't need to go into these details anymore. This is us from ASCO. Thank you.
Thank you, Dr. Jani, for bringing Chicago just last weekend back to Miami. We appreciate it very much. And I must say, I can't imagine too many things that would make 10,000 oncologists stand up and clap at the same time. Yes, one would be a cure for GI cancers, and the other would be for the government to forget about 340B pricing alterations. I think both of them would probably gain equal support. not to be pessimistic.
Yes.
But no, this was very nice. In perhaps just maybe one question, if you were head of the Department of Health and Human Services and had to invest your money, where would you invest it? Would you invest for oncology in the next decade? Would you invest it in basic science at the bench? Would you invest it in translational studies that will be brought to clinic? Or third would be perhaps improving operations and getting these medications to the populace?
I think so. I would say two places. One is
You
translation.
only get one.
Then one is what Dr. Lopes and I were working on artificial intelligence as well, trying to make and improve translational research even more easily approachable. But answer is translational research to bring it from bench to bedside, because we are doing a lot at University of Miami as well.
Good. And I'm sure you told every 10,000 people there that it was the Department of Medicine that paid for that.
Agreed. Agreed.
Anyway, well, I thank you very much, both speakers. This is a wonderful way to end Grand Rounds for the season. I want to remind everybody that indeed this is our last Grand Rounds. However, between the hours of 12 and 1 on Wednesdays, I implore you all to pick up the New England Journal of Medicine or a journal not in your area of interest. And that's what Medical Grand Rounds is supposed to do. It's supposed to widen your horizons, make you think about subjects that are not necessarily all cardiology or all hematology, maybe endocrinology, maybe something interesting in other areas. Also, pick up science and nature and read about the new discoveries that will be enabling you to translate them into clinical activity. So have a great summer. Take care of yourselves and each other. I'm always here for you, and look forward to seeing you when we resume in August.
Thank you.